Hi everyone. My name is Jennifer Marks. I'm one of the um, oncologists at Dana-Farber, specializing in thoracic. Um, and today I'll be talking to you about targeting thymic epithelial tumors, as we really need to make strides towards being able to provide better systemic therapy for this patient population. So, as you know, thymic epithelial tumors are composed of three major subtypes, generally thymoma, thymic carcinoma, and not listed here or not provided here is thymic neuroendocrine tumors. But really, there is a spectrum of disease, and trying to identify the variability of which patients are going to respond to a given treatment is still the jury is still out in some settings. And so, just to give you an overview of where we're going with this talk, generally, thymic the there are several challenges at play here with thymic epithelial tumors in that these are rare malignancies, and we have generally limited therapeutic options after we've exhausted usually first-line therapy. There are new strides towards the to making or bringing towards new agents in this space, and but generally, this remains an unmet clinical need in that these patients have high rates of either progression and or relapse, especially on the thymic carcinoma side. And we cannot, not discuss the quality of life component that contributes to treatment toxicity as we move forward to identify these novel therapies that we're bringing into the clinic. And so, while we have standard treatments in the first line setting systemically, these are by and large chemo-based regimens that for thymoma, PAC or CAP, which is a combination of cisplatin, doxorubicin, and cyclophosphamide. Not the easiest combination to handle, but certainly more evidence has been at play for using an adriamycin-like regimen in our thymoma patients when systemic therapy is indicated. Moreover, thymic carcinoma patients often will get carboplatin and paclitaxel as their combination, but the paradigm seems to be shifting as we move forward within this last year of therapy. So there still needs to be new treatment strategies available for these patients. I mean, by and large, most patients, per the rhythmic data, still get CAP or some other chemo-based regimen in the frontline setting with relatively decent tumor responses initially. Though this, of course, varies per the thymic carcinoma space as well as thymoma. But then what do we do after patients have progressed on multiple lines or on first line treatment? There is quite a bit of variability in how responsive these patients are to subsequent treatments with our current regimens. Unfortunately, there's no standard of care regimen in the second line setting, but there are efforts being made to find agents that are more active in our thymic epithelial tumor space. How should we be sequencing these agents is still very much so up for debate. This is, again, drawing on conclusions from the rhythmic study in determining which patients have received second line or what therapies are often utilized in the second line and third line space, with variability in terms of how improved improved or how good of disease control we end up getting in these patients. But what's new? Well, angioblockade has been around for a few years at this point, particularly in the thymic carcinoma space, where we utilize both sunitinib and lenvatinib with a general overall response rate more impressively seen in the thymic carcinoma setting compared to the thymoma, the cohort at least on the left side of your screen, closed after enrolling 16 patients due to limited activity. So still needing to find better agents for our thymoma patients. But what is available for our patients with use of VEGF inhibition? In thymic tumors, there's a variability, of course, as you can see, between thymoma and thymic carcinoma in terms of overall response rates, with lots of differences between the subtypes, but most activity is still limited to the thymic carcinoma setting. What's new is developing in the first line setting from the relevant trial, where overall response rate, particularly in thymic carcinoma patients, was on the order of 80%, depending on how the assessment was made, with a PFS of 8.1 months, adding ramucirumab to standard of care carboplatin and paclitaxel. Moving to our first line thymic trials, this is also being explored in other settings using similar approaches with the comparative overall response rates and duration of response. So by and large in the community, thymic carcinoma, more and more colleagues of mine are using carboplatin, paclitaxel, and ramucirumab as a new standard of care in the first line setting for thymic carcinoma patients, given the benefit of this VEGF inhibition. What about combination therapy? Well, my colleague will talk about immunotherapy in more detail, but what about combining VEGF TKIs with immunotherapy? Well, as you can see here, this has also had variability in terms of efficacy, but overall response rates are still on the order of 23 to 34%, depending on the trial and the population at hand. What about other inhibitors or small molecules? Not listed here. It's worth mentioning that mTOR inhibitors such as everolimus are also used in this space, as well as CDK4 and 6 inhibition with, in this setting, palbociclib having a modest benefit more so in the thymoma population. But what can we do moving forward? I think it will take time to find the precision that is needed for these patients in order to move the field forward and bridge the gap between management of thymic carcinoma and thymoma. There's still more work to be done, but we have learned that there are some targets that are available in this space that have yet to be explored. Moving to our TROP2-directed antibody drug conjugates, these are molecules targeting TROP2 in which a ADC binds to its target, in this setting, sacituzumab govitecan. It's then endocytosed into the cell, where it is broken up into late endozymes, and the materials within the lysosome are released and they go into the nucleus and do their directed, in this case, disruption of DNA replication. So sacituzumab govitecan, a TROP2-directed antibody-drug conjugate, is currently in clinical trials at Georgetown University with yours truly, Dr. Chul Kim, as well as Stanford and the John Theurer Cancer Center in New Jersey. But this study is looking at using sacituzumab govitecan in patients with both thymoma and thymic carcinoma in the second-line setting. And so these patients are the cohort B, I believe, is still or is recently filled, but I'll let Chul Kim comment on that further. However, the advanced thymoma setting is still active and available as a treatment option for these patients who have progressed on one prior line of therapy. What else is available? Well, P2112 in thymic epithelial tumors is a first-in-class pyrophosphate platinum conjugate. This agent is thought to cause immunogenic cell death in preclinical models, leading to the recruitment of tumor-infiltrating lymphocytes. And so based on while the data is still very early, with these solid tumors at various doses, there have been observed durable pathologic responses, also being studied in non-small cell lung cancer and small cell, but most seen often in the thymoma candidates. What else is available? Well, discoid domain receptor is an expression that is associated with collagen and immune cells for tumors, and this is highly expressed in thymic tumors. And this agent is also available or is in active clinical trials and in the States, and is being developed for thymic cancer patients. As you can see on your right side of your screen, the visual improvement, at least in cutaneous metastases observed looking at the chest wall, lungs, and rib metastases as you move to the right aspect of your screen. What about other targets? Well, MTAP deletion is a newer agent or a newer target that's being studied in multiple solid tumors, but is also seen in thymic carcinoma particularly. The thymoma setting is underexplored, at least in this population of 20 patients. There was no MTAP loss or CDKN2A and B, respectively. However, there are smaller studies or other studies that have seen thymoma have some of these deletions expressed in thymic epithelial tumors as well. So this warrants further exploration and investigation in at least the second-line setting to determine whether or not this could be a modality or an agent that we use in the future. So what are the directions we should be heading towards? Well, while we have systemic chemotherapy, this again is a clinical challenge for our patients as they have toxicities associated with triple chemotherapy, especially in thymoma patients, with the need for ideally better treatments available moving forward. Recent trials, of course, show angiogenesis as a target is something that we can utilize to, especially in the thymic carcinoma space, as well as targeted therapies are further being explored. And you'll hear more about immunotherapies in the next section. This is really reshaping the treatment paradigm, especially in first-line thymic carcinoma patients with the addition of ramucirumab to carboplatin and paclitaxel. However, of course, there are more opportunities and here to explore molecular profiling in these patients in order to get a better understanding of what targets are available. This will require additional assistance and collaboration between centers in order to navigate the vulnerabilities that are potentially present in targeting these malignancies or these tumors that are so challenging to treat. More research and advocacy is needed here in order to shape better treatments for these patients, and we'll have more emerging development in the future with the addition of these target therapies as these trials continue to read out. Thank you very much.